Okay, hello and welcome back to Pharma Girls. Yes, I'm back at it again, and this is just a picture to help you remember the extra information about each drug that's kind of hard to remember. So I'm not going to explain the main concept of peptic ulcers or GERD, but I'm going to talk about the drugs straight away. So here are basically the drugs that we have, and if you can remember, we have proton pump inhibitors, H2 receptor antagonists, antimuscarinics, prostaglandins, sucralfate, bismuth compounds, prostaglandins, antacids, and to eradicate Helicobacter pylori, we have antimicrobials. Okay, so first, yes. So starting off with our first drug, proton pump inhibitors. So we have two examples. We have omeprazole and pantoprazole. And as you can see, she's panting. So just to remember. So what does it block? It blocks the terminal step in acid secretion. So they're proton pump inhibitors. So they inhibit the hydrogen potassium ATPase proton pumps that are in parietal cells. So they block this. And parietal cells secrete HCl. So they reduce the acid that's being secreted into the lumen. So this drug is the most effective in preventing ulcers. So number 1. Okay, so just to know that proton pump inhibitors are prodrugs. Number 1, prodrugs, and they require to be activated in the acidic environment. So when it's absorbed by the systemic circulation, it's going to diffuse into parietal cells of the stomach, and then it's going to accumulate into the acidic canaliculi. And then it's going to activate over there, which will make it work basically and prevent the acidity. So something to know about proton pump inhibitors is that they should be taken on an empty stomach. Now, if we go back here, you can see there are like 3 characters wearing red t-shirts, and this means that they should be taken before meals. So proton pump inhibitors should be taken like 30 to 60 minutes before a meal. And because it suppresses acids, you shouldn't give it another drug that you shouldn't co-administer it with another drug that suppresses acids, because that's going to be just too much. Okay, so something about omeprazole, we're talking about omeprazole, okay, is that it inhibits cytochrome P450. Now, what do we know about cytochrome P450? We know that it's important for the degradation of some other drugs. So when proton pump inhibitor omeprazole was given with these drugs, such as we have warfarin, phenytoin, diazepam, and also theophylline. Okay, well, we give these 4, or like one of them, with proton pump inhibitors. This is going to not make them degrade, no degrading, which will cause, as you can guess, toxicity. So sad. So you shouldn't give omeprazole with those drugs. Okay, and as you can see over here, so spoiler alert, this character is going to be the H2 receptor antagonists, cimetidine and ranitidine. So as you can see, she's a bit jealous of her because proton pump inhibitors are superior in suppressing acid in comparison to H2 antagonists. So again, this is the superior one, first line management. It's good for GERD, peptic ulcers. We have something here called Zillinger-Ellison syndrome. Like, keep that in mind. Gastrinomas. And it helps prevent and treat NSAID-induced ulcers, acute stress ulcers. As you can see, there's a lot of ulcers. And also, it's good at eradicating H. pylori if given with an antimicrobial. And also, it's good for aspiration pneumonia. So, a lot of things because it's a very cool drug. Okay. But you need to be careful of it in cases of liver disease and pregnancy, also breastfeeding. Okay. We may have some other adverse effects. So headaches, diarrhea, as you can see she's clutching here, abdominal pain. Now we said that it acts on parietal cells to inhibit their activity. We know that parietal cells secrete HCl, but they also release intrinsic factor. So when parietal cells are suppressed, intrinsic factor is also reduced, which will cause vitamin B deficiency. Okay. It also causes osteoporosis. You can see in the phosphatidylate. It causes osteoporosis because there's less absorption of calcium, and this is going to lead to bone loss and hyperthyroidism. So we have a risk of hip, spine, wrist fractures because now we have weaker bones. And we increase the risk of enteric infections. Why is that? Because we decreased acid greatly, and this will lead to an increase in invasive pathogens such as Clostridium difficile and Shigella. We also have intestinal nephritis, hypergastrinemia, and there could be tolerance. Wait, let me just make sure. What is intestinal nephritis? Okay, so it will cause swelling of kidneys. Okay, as you can see here from the drawing, so everything red, they're like on the same team because this theme is like marathon or like track event or something. So it causes intestinal nephritis. And this is an inflammation of the kidneys. Interstitial. Yes. Okay, interstitial nephritis. And that's all we have for proton pump inhibitors. Okay, for our next drug, we have histamine receptor antagonists, H2 receptor antagonists. We have cimetidine and ranitidine. So she's literally the only one running, ranitidine. So what do? They competitively inhibit H2 receptors that are also in parietal cells, and they're very effective in inhibiting nocturnal acid secretions. So we have the moon and star indicating nocturnal acid secretions. Something to note is the adverse effects. So we have skin rash, as you can see, skin rash, headache, and diarrhea. Basically, they have the same adverse effects. Basically, they have similar adverse effects, but H2 receptor antagonists, they have the skin rash. And if given intravenously, this is very dangerous. So avoid IV. No IV for histamine receptor antagonists. Why is that? Because the H receptors, the histamine receptors, are also found in the heart. So you can imagine what could happen. So if you block them, you have bradycardia, decreased blood pressure, confusion, hallucination, and agitation. So as you can see, she's confused and a bit agitated. خير ليش هذه فازت? I'm so much better. Yeah. So more adverse effects are that histamine receptor antagonists have androgenic effects. They have anti-androgenic effects. So they'll inhibit the binding of dihydrotestosterone to their androgen receptors. So basically that means that we have less testosterone. What can you imagine could happen? Gynecomastia. Okay. And we have hyperprolactinemia, which is the increased production of breast milk. So look at the fit. استغفر الله يعني شوي محرج الموضوع بس يعني it's just a cow brand. You can indicate that it's about milk production. Something else is that H2 receptors also inhibit CYP 450, and they decrease hepatic blood flow. So what will this do? It'll also inhibit the metabolism of the co-administered drugs that we said. For example, what were they? We had warfarin, we have phentoin, we had theophylline, and what else did we have? We had diazepam. So these four, if you remember, yeah. They also shouldn't be administered with H2 receptor antagonists. Something else is that antacids, we're going to talk about them later. Antacids, they will decrease the absorption of H2 receptors. Why is that? Because for its absorption, it needs an acidic environment. So if we have antacids, they're going to increase pH. They're going to decrease the acidic environment. Therefore, it cannot be absorbed. And that is a problem. And this is all we have for our H2 receptor antagonists. Now, for our character over here, pyrazine. So I made her a pirate. I wonder why. Pyrazine, just to remember. So pyrazine is an anti-muscarinic. Why is that? Because parietal cells, we're still on parietal cells. Parietal cells have M3 receptors. If we block these M3 receptors, this will decrease the secretion of acid and thus decreasing pepsin. Okay. So the adverse effects, we remember the adverse effects of antimuscarinics, which is the flushing and urinary retention, and the rest. Okay, the dry mouth, blurred vision, and also constipation. So these two over here had diarrhea, but pyrazine antimuscarinic has constipation. So cautions, do you remember what we warn about for antimuscarinics? We don't give them in cases of glaucoma, benign prostatic hypertrophy. And unfortunately, they're not commonly used because they have low efficacy. literally ما لها دخل في الموضوع يعني in her own world. So that's all we have for the antimuscarinic pyrazipine. Now on to prostaglandins. So here's a character you might remember, which is misoprostol, one of the prostaglandin analogs. So first of all, what do prostaglandins do? So prostaglandins in general, they decrease gastric secretions, increase mucus production, and also increase bicarbonate secretions. They do all these three. Decrease gastric secretions, increase mucus production, and increase bicarbonate secretion. So additionally, they will dilate the mucosal blood vessels. So basically, they protect the cells. They work at they increase the barrier for the cells. So NSAIDs induce peptic ulcers. If you remember ibuprofen and aspirin, because they inhibit COX-1. Therefore, we need prostaglandin analogs to counter that. So if we have NSAID-induced ulcers, we could either decrease the NSAID dose, because sometimes we still need it, or we can add misoprostol, or we can change, for example, paracetamol, which could cause peptic ulcers. We could switch them to, for example, celecoxib. If you remember, celecoxib is a COX-2 inhibitor. So it doesn't inhibit COX-1, and inhibiting COX-1 is the problem. So we can use this instead. So we can also use a proton pump inhibitors to treat the NSAID-induced gastric ulcers. But, my bad. When we still need to use NSAIDs, the best thing is to use proton pump inhibitors. So they're going to treat and heal the ulcers, and you can continue taking the NSAIDs. So if we're going to use the prostaglandin analogs, for example, misoprostol over here. So first you need to know that it's taken 3 to 4 times a day, and that it binds to the EP3 receptor, where also on parietal cells, because parietal cells are the ones that produce the HCl. So as you can see, here's EDP, infamous YouTuber. I just ذكرني الموضوع فعلى طول هتلاقي. So misoprostol from our last picture, she was protesting a cause, so she's always protesting something, and this is a good cause actually. She's always on to something. Anyways, so misoprostol will bind to the EP3 receptor on parietal cells. This will decrease gastric secretions, stimulate mucus and bicarbonate production, and also increase mucosal blood flow for healing and stuff. So it's used to prevent NSAID-induced ulcers. And also, if you remember from our last picture, let me just find it real quick. Here it is. From our last picture, we also remember that it's used for abortions. It's given in the first trimester. Important that it's in the first trimester. because if it's after that, it's dangerous for both the mother and the child. It's dangerous for the mother and the fetus. So adverse effects, we have abdominal cramps, diarrhea, and uterine contractions, also if we remember from this picture. So that's why it was used in general. It's used to induce uterine contractions, but sometimes if we don't want it, it could cause miscarriage. So, of course, contraindicated in women of childbearing age, pregnancy, and also something new. Can you not? Irritable bowel disease. Why is that? Because we're giving cramps, we're giving diarrhea, irritable bowel disease, monogus, honestly. That's what we have for misoprostol. Now over here we have a new drug called sucralfate. I forgot to write it, so sucralfate. Sucralfate. So sucralfate, whatever. Sucralfate. So what is sucralfate? It is an aluminum salt of sulfated sucrose. So we all know what sucrose is, and it literally goes no sucre. So what does it do? Now it's going to utilize the stomach acid. It's not going to block. No blocking. So it's going to utilize the stomach acid and form a protective barrier over the ulcer. So it's going to form the protective barrier over the ulcer to protect it from the aggressive factors in the lumen, such as the acid, the pepsin, and the bile. So the red t-shirt, it's also taken on an empty stomach. So last one we said 30 minutes to an hour. Here it's like an hour before a meal. So again, sucralfate, it shouldn't be given with antacids, just like we said for the H2 receptor antagonists, because antacids in meals should not be taken within 30 minutes of sucralfate, as they may increase gastric pH and alter the physiochemical properties of sucralfate. So sucralfate needs the HCl. If you give the antacids, what are they going to do? Again, they're going to increase the pH, meaning they're going to decrease the acidity, which means that sucralfate can't work anymore. It's not able to do what it does usually. So here's sucralfate's gym bag, where she keeps her stuff, because she's like, she's PPI's coach and everything. So okay. So as you can see here, sucralfate will cause something called aluminum toxicity in chronic kidney disease. So people with chronic kidney diseases should beware, because it could give them aluminum toxicity. Why aluminum toxicity? Because the structure of sucralfate is aluminum salt of sulfated sucrose. Okay. Also, it can cause constipation. What else did we say could cause constipation? The antimuscarinic pyrazinamide. Pyrazine. Okay. Pyrazine. And something about it. So she's PPI special coach. So she's very biased, and decreases absorption of certain drugs. What are these drugs? Phenytoin, digoxin, and ketoconazole. Okay. So adverse effects, it's going to cause constipation, hypophosphatemia, and aluminum toxicity. Okay, now on to bismuth compounds. So bismuth subsalicylate or bismuth subcitrate potassium. Its mechanism of action is that it's going to interact with glycoproteins in necrotic mucosal tissue. So now there's already the tissue that underwent necrosis due to the ulcer. It's going to interact with that to form a protective barrier to prevent further aggravation. What else is that it's going to stimulate prostaglandin. And what do prostaglandins do? They're going to increase mucus and bicarbonate. It also, so as you can see, so it has a direct antimicrobial activity against H. pylori, unlike proton pump inhibitors. And also, it binds to enterotoxins, and it's helpful in traveler's diarrhea. I was going to draw something, but I think I forgot to when I was coloring. So, its uses. It's used in quadruple therapy for eradication of H. pylori infection. So I have these over here for quadruple therapy for H. pylori. And as we said, it's useful for traveler's diarrhea. Okay. Adverse effects is the blackening of tongue and stool. So it's basically reversal when the patient stops taking medication. So there's nothing more you can do about it, nothing really to worry about, but it's important to know. So blackening of the tongue and stool, and prolonged use could cause encephalopathy. So it's going to cause imbalance, ataxia, headaches, confusions, and seizures. So I hope you're very confused. I also forgot to add the question mark over here. Now, antacids were a lot more complicated for me to cover. So, I couldn't capture everything in one drawing. All I did was that they are in the background. So they're pretty weak, not much for competition. They're a weak base. They don't inhibit something. They're neutral, so they neutralize the acid. And over here, as you can see, there's this water bottle, and it is because it causes fluid retention in patients with heart failure, hypertension, and renal insufficiency. There's a lot more that you can go back and read for yourself. And lastly, for GERD, I just added this quick drawing. As you can see, first line. So as you can see, the manager team over here, they're the managers for pantoprazole and omeprazole, proton pump inhibitors, basically. So here they are together. They work together as first line for GERD. Second, we can use ranitidine. And if it's complicated, persistent, severe, we use proton pump inhibitors because she's just the best. And yes, that is all I have. شرحي شوي خربوطي, بس I hope this helped in a way. And also here are the important graphs that we had in the lecture. So just to understand, antacids neutralize, proton pump inhibitors, H2 receptor blockers, and in prostaglandins, they decrease the secretion of HCl, where with prostaglandins increasing mucus and bicarbonate, and sucralfate and bismuth compounds, they add the protective barrier. And here we can see the receptors that each one acts on. So M3 receptors, muscarinic antagonists, pyramine. Let me make sure because I keep forgetting. Pyrenzipine. Okay, pyrenzipine. So pyrenzipine is going to act on... Whoa, okay. Pyrenzipine is going to act on the M3 receptors. When it acts on the M3 receptors, this is a calcium-dependent pathway. So with calcium, then it's going to decrease the activity of the hydrogen-potassium ATPase. Whereas proton pump inhibitors, they directly act on the hydrogen-potassium ATPase. Antacids here, they're going to neutralize the hydrogen that's going to be in the lumen. And histamine receptor antagonists, they're going to antagonize the H2 receptors. And here we have a CMP-dependent pathway. So here is a calcium-dependent pathway, here is a CMP-dependent pathway, and they're all going to lead to inhibition of the hydrogen-potassium ATPase. Misoprostol here is going to act on the EP3 receptors, which are going to act on two different cells, parietal cells, and with parietal cells it's going to inhibit the secretion of HCl, just like the other three. But on the superficial epithelial cells, it's going to increase mucus and bicarbonate. This is the protective barrier. We have our muscarinic antagonists here as well, but we focused more on the M3 receptors. As you can see, pyrenzipine, here we are. And yes, over here, the bismuth compounds, they're going to act on H. pylori with the quadruple therapy as we mentioned before. So again, this is what I have. You can revise the antacids from the lecture and including the general concepts of peptic ulcers. My whole goal was to draw something for you to remember everything a bit more nicely. And yes, now this is all I've got. Thank you.